Hi everyone, this is Teresa Rich from Reflexology UK in Bournemouth, and I've got the lovely Barbara Scott, okay, talking about reproductive reflexology. I just want to first of all say thank you to everyone for coming on the line. I know you're all from different places, so I always like to first of all find out where everyone's from, just roughly which part of the globe or UK people are from. And so, first of all, in order to do that, what you need to do is you need to put in the questions box where you're actually from. So that will be a good start. If you can see the questions box while they're coming in, Barbara, I just wanted to mention to people you can wave your hand at me, that not physically like this, but there is a hand icon in the side that you can actually wave to get my attention, like if you've got a question. And you can also put, not a question yet, but during the presentation with Barbara, she's happy to take questions as we go along. So feel free to put any questions that you may have as the presentation goes on. It is solely 45 minutes only, okay, because this is her time, her free time that she's coming on. And, you know, I appreciate all of you coming in on your lunch hour as well. So I think that's about it for now. Let me just see where everyone's from. Where are you from, Barbara? Where are you based?
I'm based in Southwest Wales in Carmarthen.
Fantastic. So another Welsh person. Brilliant,
Yeah.
brilliant, brilliant. Right. Okay, so here we go. I've got someone from Greece, Maria. I can't say your surname, Maria, but she's from Greece. Pamela from Northern Ireland. I've got a couple of people from Ireland, actually, which is brilliant. Lovely to see some of my students on here, Angela Philpott and Jacqueline Lowe. Great. Another lady from South Wales, Marilyn Hodges, you may know, I'm not too sure, which
Oh,
is super. Some people from Kent, Cornwall, and my lovely friend or colleague, should I say, Jill from Canada. So there's a whole array of different people from different parts. So Greece is the first time I've seen someone from Greece, which is brilliant, absolutely brilliant, really good. So without further ado, I'm going to let you come in with it, Barbara. But before you actually start, can I just say about people's connection? Because sometimes people email me and say they didn't hear it or what have you. It depends on your internet connection and your internet provider. So if you lose the line, if you've got a bad line, that will be your end. It is being recorded from here. Okay, so let's welcome Barbara, everyone. Brilliant, absolutely brilliant. Barbara, over to you.
okay. Thank you so much. And how wonderful to hear from so many people from all over the globe. That's quite extraordinary. You're obviously doing amazing things there, Teresa, bringing so many people together. Absolutely great. Okay, so I'm just going to give you a little flavour of what reproductive reflexology is and how we work, and it is just a little taste really of why it's different to ordinary reflexology, and we've got a little case study which really gives you a little example of that. So what we're going to look at is what is reproductive reflexology, what happens at initial consultation, because we have a consultation process that works quite differently probably to what you're used to doing in traditional reflexology. And then we've got some stats which we did. We did a data collection which shows you how effective it is as a form of treatment. And actually we have a stand at the fertility show at Olympia this year. We've done this for the past couple of years. There is a big exhibition at Olympia, and I've been asked to speak again this year. I spoke last year in the complementary medicine section and have been asked to do so again. And we will be presenting these stats there alongside more traditional forms of treatment for fertility conditions. So that's quite an exciting thing for us to be doing. Okay, so what is reproductive reflexology? One of the things to remember and this is really key to how we work, is that when we're looking at fertility issues, the causal factors are attributable a third male, a third female, and a third joint. And in orthodox medicine, the males are very much sidelined. And so we think that it's really important that we engage with our males as well as our females. All of you know that you have many, many more women that come to see you than men. And so we have spent a long time thinking about how we engage men, because it is key to the success rates for our couples when they come forward to treatment. So that's why what we like to do is this initial consultation. And what we do within that is we send out what's called a preconceptual questionnaire, so that we start to build up all of the pieces of the jigsaw puzzle, and we make sure that we don't actually miss anything. So what reproductive reflexology does is uses very specific and structured prescriptive treatment protocols for both men and women. We actually set out to achieve something. So, you know, when people come for orthodox reflexology, they come and they might tell you what they have wrong with you and them, and you would go and have a look at their feet and feel their feet and feel which parts feel out of balance. And we do something quite similar to that, that we do an assessment, but we also actually use reflexology to try and make changes to any conditions that might be present and any anomalies with menstrual cycles, etc. So we aim to treat any underlying conditions, both male and female. We aim to regulate menstrual cycles, so we work very specifically at each stage of the menstrual cycle, okay, to make sure that each component part of the menstrual cycle is doing what it should be doing. So what that means is we have a very structured protocol that works during the bleed, it works from the end of bleed up to ovulation, it works improve implantation rates, and then it works to support the early stages of any possible pregnancy. So it is very prescriptive. We also work with men to improve sperm production and its functionality. So many men will come because what we have discovered, or what has been discovered through research, is that male fertility has declined in this country by 50% over the last 25 years. That is a massive amount, and it is reflected around the world. The two main studies that were done were in Denmark and in France, and it's certainly very much what's happening here in the UK as well. So we know that male fertility is declining for a whole range of reasons, from things like having estrogens in our water, to very high stress levels, to being exposed to various chemicals, to polluted food chains, etc., etc. So there is an awful lot that we need to do to improve our males and their production of sperm. As I was saying, we also use these prescriptive treatment protocols alongside all forms of assisted conception. So our aim is to treat couples initially for 3 months so that we can improve their overall health and well-being and help them to conceive naturally. But there are many, many couples for whom assisted conception is going to be the only answer, or for whom they've into a system and they want to pursue that. And we want to be able to support them through that form of treatment. And I was taught, probably very much as you have been taught, that this is when it's hands off. And what I discovered after sort of 20 years of working with these kinds of clients is that this is actually when they need the most support. All right. And so what has happened over the years is that I've developed a range of protocols that turn reflexology on its head. So we use reflexology to support the drugs and treatment protocols that our clients are undertaking. So it's using it in a different way, and it improves efficacy and outcomes. So we work alongside medicated cycles, IUI, which is intrauterine insemination, IVF, in vitro fertilization, and ICSI. And the main difference between those two things is that ICSI, which stands for intracytoplasmic sperm injection, involves taking over the fertilization process. So basically the clinic will actually inject the head of the sperm into the egg to make sure that fertilization takes place. And we have protocols that work to support all of those varying kinds of assisted conception. Reproductive reflexology really is, at its best, one of the most important forms of integrated medicine. We use medical testing to find out what the issues might be with our clients, and we also use medical testing to measure improvements and outcomes for both males and females. Which leads me on really quite nicely to talking about the collaboration that we formed with Professor Sheena Lewis. Sheena Lewis is based at Queen's University in Belfast. She is a professor of reproductive medicine who specialises in treating males, and has developed a test called the Sperm Comet test, which looks specifically at the DNA in the head of the sperm. And this is key because she did a study many years ago now, probably about 5 or 6 years ago, which looked at couples who had unexplained infertility, and they looked at 239 couples, and of those 80% of the males had elevated sperm DNA fragmentation. And that leads to elevated levels of non-implantation, so eggs that are being fertilized, creating an embryo but not implanting, and elevated levels of early miscarriage, so having repeated early miscarriages. And also, if they go beyond that, then babies that are born with very specific conditions like chromosome deletions, etc., which is obviously very distressing. And what happened was that Professor Lewis heard about the work that we were doing. She invited us to go over and visit the labs and meet with her. And we have now formed a collaboration with her, which means that all of our practitioners are able to offer this test to their male clients. It is very cutting edge. It is very new, and it is the only test of its kind that allows us to look at male fertility in this way. And what we have developed is a means of treating poor results using reflexology. So we launched a specific protocol that improves the outcomes. And the reason it improves the outcomes is sperm with damaged DNA are usually caused by high levels of oxidative stress, which causes elevated free radical levels, and they damage sperm. And what we have is a protocol that reduces that. And so we see positive outcomes as a result of it. So that's very exciting for us as practitioners. Okay, so I'd like to go on to talking about an example, a very sort of straightforward, easy example that might help all of this to make a little bit more sense. One of the things that we are most likely to come up against when we are working reproductively with women in particular is women with issues during the luteal phase of their cycle. So that is the stage of their cycle from ovulation to bleed. And most women, when they are looking at their cycles, really have very little idea about how they work. have an idea, the thing that they're most focused on is whether they're ovulating or not. And what we do is we use basal body temperature charting, which tells us not only when they're ovulating, but it tells us about their luteal phase, whether they're producing sufficient progesterone levels. It tells us whether they are ovulating at the same time. It tells us whether they're producing the right fertile cervical mucus at the right time in their cycle. And it's also a fantastic tool for measuring the effects that reflexology is having upon their menstrual cycle. So this is a good example. So we have a female. This is actually a client of mine, and it's just sort of the basic information about her. But she, as I say, she's a good example with a short luteal phase, and she had progesterone deficiency. So basically, the period of time from ovulation to bleed was too short, because it was 10 days or shorter, and also her temperature levels were dropping sooner than they should have been. I've got some charts to show you which give a good example of that, which show us that her progesterone levels were dropping too soon. Now we can also check progesterone levels medically by doing a blood test, which should be taken 7 days post-ovulation. It's one of our real bugbears because it's called the day 21 blood test for women, and it is quite often taken on day 21, which quite often is the wrong time. It needs to be taken 7 days post-ovulation. So if you have women who have a 35-day cycle, for example, and you take their blood test on day 21, it's highly likely that they won't have ovulated by that stage. Most women have a luteal phase of between 10 and 16 days. If she has a 35-day cycle and she does ovulate 14 days prior to her bleed, then she won't ovulate until day 21 of that cycle, and therefore the test would be completely inaccurate. So we use temperature charting to find out exactly what is happening. And in this particular client we're going to look at, I'm going to show you the chart and you will be able to see what is happening for her. I'm going to, actually, I shall. Bear with me because I want to show you the chart first of all, and we will go back to those things. So in this chart, what you can see is the blue dots and the blue lines, which tell us that our client's temperatures each day of her menstrual cycle. The lines that are broken are times when she's mistaking her temperature, so it can make it a bit more difficult to read. But what you can see, if you look along the bottom, it says days 1, 2, 3, 4, 5, 6, 7, 8, etc. And underneath that, the next line, it tells us what is happening with her cervical mucus. So it says CM, which stands for cervical mucus. And for the first 4 days, it's pink, and it's got 3 M's, under 1, 2, and 3, and under 4 it's L. And that just tells us that she's menstruating. Day 4, it's a light bleed. And what you can see is her temperatures are fairly steady, and then at the end of that, the temperatures start to drop down, and they drop down right the way until day 16 at their lowest. And then on day 17 of her cycle, you can see that her temperatures start to rise. Yeah. And on day 18, there is a little green box which says E underneath day 18, and that stands for egg white mucus. That is what we want to be seeing around the time of ovulation, because it tells us that she's producing fertile mucus, the right kind of mucus at that stage. Without fertile mucus, it's highly unlikely that she would conceive. So these are some of the really important pieces of information that that we need when we are assessing what's happening to our clients. And then what you can see is her temperature levels, that blue line, starts to rise. And you can see that the levels are much higher than they are prior to ovulation. So in this chart, this computer-generated chart has assessed that ovulation has taken place on day 17 of her cycle, and we have this lovely red line that goes through day 17, and then a horizontal line which crosses that, which allows us to measure the elevation in temperature. So what you can see is that her temperature remains, although it fluctuates, it remains high until day 10, and then it starts to drop and it plummets after that. And so she only has a very short luteal phase. And with this woman, it was a real issue. One of the things that we found out was that her progesterone levels were rising, but slowly, because the temperature rose slowly. You can see from day 16 there isn't a sharp increase, there is a measured steady increase. So her temperature levels were, and therefore her progesterone levels were, rising only slowly. And then it dropped quite suddenly and far too soon on day 11. All right, so we needed to remedy that, because what that told us was that there was insufficient time for implantation to take place effectively, and even if implantation had taken place, then it was highly likely that because her progesterone levels were dropping, she wouldn't sustain the pregnancy. So it meant that we really needed to do something about it. What you can also see underneath the chart, and this is key, is there are 3 lines. You've got cervical mucus, which we've already talked about. We've got notes, which allows our clients to add little notes about what else might be happening for them, what symptoms they may be having. And they also have underneath that a line that says BD. Now BD stands for baby dance. It is a really just an intriguing way of saying that they've had sex. And some couples actually do forget that they have to have sex.
Yes, exactly.
They think there's going to be an immaculate conception, particularly when they start taking some drugs. So that's key, that we make sure that they're not only are they having sex, but they're having sex at the right time.
Yes, that's very important.
So really important, and it allows us to find that out without having to ask them, because they can get a bit uncomfortable about it. One of the other things I wanted to point out on this chart was, if you go back to the cervical mucus line and you look underneath days 24, 25, 26, 27 and 28, you can see little asterisks. Now those asterisks mean spotting. So that tells us that our client was spotting for 5 days prior to her bleed. And some women start to include that as part of their bleed, and it isn't. But what it does tell us is that her progesterone levels are not sufficient to maintain an intact endometrium, and that will be having a very significant effect upon her trying to conceive. So how do we treat it? So bear with me just while I go back some screens. Let's just go backwards. Okay, so we would treat our clients weekly throughout their menstrual cycle. That's the first thing we would do, and we have a weekly protocol that mimics what the body should be doing. So we actually look physiologically at what the body should be doing from an endocrine point of view and from a physiological point of view. And are you just asking if everyone can see the screen, Teresa?
Checking. I can see it, but I was just asking if everyone else could see it. Yes, they can. That's brilliant.
Okay.
That's all.
Okay, brilliant.
Check.
Okay, great. Okay. We would also treat specifically from ovulation to bleed, stimulating the ovary reflex point to enhance the production of progesterone. Once your clients have ovulated, what is left behind in the ruptured follicle in the ovary is the corpus luteum, which is a yellow mass that produces progesterone. And so we work directly with that to try and encourage the production of increased levels of progesterone. And we may also recommend that our clients self-stimulate their ovary reflex points, beginning with 3 times daily for 60 seconds to support what we're doing on a weekly basis. So it's just this gentle, continual nudging of the ovary reflex point to improve the levels of progesterone. Okay. We also use ongoing monitoring, so they continue to take their temperature and monitor what's happening with their cycle. So we would see an improvement in their symptoms, so the spotting would stop prior to their bleed, their PMS symptoms, because you tend to find that progesterone deficiency causes enhanced PMS symptoms, and also they can get cyclical headaches. So as soon as they ovulate to bleed, they tend to get a lot more headaches. You tend to find that will improve, and you would be able to see changes in the basal body temperature charts, which I'm going to come on and show you. Okay. We would also...
I've got a question here from Maria, and she said the ovary reflex that you're saying for them to stimulate, is that just on the foot, or can it be on any of the other parts of the body, like the hands or the face and so on?
Okay. Our point, and the point that works most effectively, is on the foot. I think hand reflexology points are far too difficult to treat yourself and for clients to find them accurately. So we always teach them how to find the reflex point on the foot and work that precisely. And one of the things I will say here is what you have to remember is that ovary reflex points on the foot are not always where you would expect to find them. Because for some women, they may have an ovary that is tucked round behind the uterus. It might be quite high up, it might be low, it might be in front of the uterus. So when we teach what's called the repro assessment within the course, we teach you to feel very specifically for where individual ovary reflex points are, because they can be in different places.
Yeah,
and quite often they're a lot higher.
And she says thank you, so that's great.
Oh, a pleasure. Okay, so repeat the progesterone test, most specifically 7 days post ovulation, so making sure that that's been done at the right time. And here we have, so the previous chart which we were talking through was from a client of mine, and this is the result post-treatment. So what you can see is we have ovulation, which has moved forward slightly. It's happened on day 12. You can see that red line through day 12. We have a far better increase in her levels of progesterone immediately. So if I go back, what you can see was here, she ovulated day 17, and we had this sort of, it was probably maybe day 16, 17, I think, ovulation on this chart. But what we had was a very gradual rise up until day 21. So it rose over 5 days. If you look at the next chart, we've got a significant rise in 1 day, which is exactly as it should be doing. And then the levels remain high, and they stay up for 16 days, and then we get the drop on the day that she starts her bleed. All right, so a much, much better chart. If you also then go down to look at cervical mucus, she's producing much better levels of cervical mucus, fertile cervical mucus. From day 8 to 13, she's producing egg white cervical mucus, and then this sort of watery, more profuse. So that's perfect, because you need to have cervical mucus produced prior to ovulation, because the rest of the time cervical mucus is hostile to sperm and will kill sperm because it is the wrong pH. So if in fertile mucus it produces lovely channels for the sperm to swim in, it produces nutrients, it changes its pH, and what we need is We need sperm in situ before ovulation takes place, because if they are there post-ovulation, it's too late. The egg is only fertilizable for about 8 to 12 hours. So, you know, if you ovulate at 8 o'clock one evening, by 8 o'clock the next morning, then the egg is probably of no longer fertilizable. So we need to have sperm in situ before ovulation takes place. If you look further along that column, whereas previously we were seeing 5 days of spotting prior to her bleed, the spotting has stopped. Okay, she's got some, C stands for cloudy mucus. She's just got ordinary you know, cloudy cervical mucus, which many women produce at that time. So much better. If you look at the baby dance column, you can see, or line, row, whatever you want to call it, you can see that they had baby dancing on days 10 and 12, which is absolutely perfect timing. So it allows us to make sure that they're getting their timing right. The other interesting thing that you can see at the bottom of this chart is something that says OPK, which stands for Ovulation Predictor Kits, which I'm not a fan of, because what you can see is she's just got 2 negatives. The little line means a negative. It's not actually showing any positives at all, and yet we can see very, very clearly that she has actually ovulated.
Brilliant.
But the Ovulation Predictor Kit is not picking that up.
Jacqueline Lowe actually has just asked, how long does the sperm live for? You know, I suppose it's different whether it's healthy or unhealthy, surely, anyway. But
it is.
How long does it generally live for, she's asking?
Okay, so good, strong, healthy sperm will survive for 72 hours up to a week in the right kind of cervical mucus. So we usually say to clients, once we've got their cycle regulated and his sperm improved, if they make love 3 times in the week leading up to ovulation, that's all they need to do. All right, gives the sperm time to get to where they need to be. And what happens to sperm is they will swim. They will swim to where they need to be, which is the end of the fallopian tube, and they rest. They go into suspended animation, and when ovulation takes place, so that change in hormone levels actually wakes the sperm up and they become active again and then able to fertilize the egg.
Brilliant. Hope that's answered your question, Jackie. Hopefully. It's good.
Yeah, I hope so. Okay. So, treatment for men.
Exciting.
Yes, really key. As I was saying right at the beginning, male fertility has declined phenomenally, not only in this country but around the world. So declined by 50% in the last 25 years, and we are seeing those levels continuing to decline. When I first started working in this 20 years ago, a normal reference range for morphology for men, so that is the formation of sperm, was 20%. If it was lower than 20%, then it would be classed as abnormal. It reduced to 15%, it then reduced to 9 to 11%, and it now stands at 4%. So you can have males who have 96% of their sperm abnormally formed, and that will be classed as a normal sample. And that is a direct result of male fertility declining.
Scary.
It's frightening because it means that 96% of those sperm are of no use whatsoever. So we need to be working with our males. They are key, to what happens. So we also want to work in reducing levels of stress, improving the function of both their reproductive and endocrine systems. And what we have is a weekly protocol which allows us to do that. So we have a program that means that we treat men weekly for 8 weeks, and then usually we continue fortnightly. And how the program works is that we assess them, we treat any underlying conditions. So For males, one of the most common things is prostate conditions. Many men have prostate conditions, whether it's an episode of prostatitis, so inflammation of the prostate, or chronic prostate conditions where it has become diseased. It has an enormous effect upon fertility. So I probably, well, I think Sheena Lewis says 90%, but somewhere between 60 and 90% of the seminal fluid is produced by the prostate gland. So if you have males that have a prostate condition, it most definitely will be affecting the quantity, the quality of their seminal fluid, and the seminal fluid will be causing damage to the sperm. So one of the most common things we see is prostate conditions, and we have a very specific treatment protocol for treating that. So we may treat their prostate condition, and then we would use the weekly protocol, which is used to enhance and improve volume and quality of sperm. And we would do that weekly. And then usually for males, because they're in for the long haul, the difference with women is that you can see changes almost on a weekly basis, and we can feel those changes in the feet. With men, you might be able to feel the changes, but it's intangible for them. And the only tangible way of doing it is a repeat semen analysis. And again, this is where integrated medicine comes in very well, because we're using medical testing to show how effective reflexology is being as a form of treatment. And what you see is the parameters all rise. So, you know, if you've got someone who's got very poor sperm count, you would expect to see that rising and improving. We had someone, we have for our association members, we have a closed Facebook page, and we had someone who posted recently that she'd had a male come to see her with 0 sperm count, and when she'd finished treating him, it had gone up to 5 million. Now, that's still quite low, but what it means for him, or for them as a couple, is that they would be able to have a child that is biologically theirs rather than having to use donor sperm, and that's a big issue. So you can make small changes that have a big effect on couples. All right. So treating males is key to what we do. It is very important. Okay, so I just want to talk very quickly about what happens at initial consultation. We firstly send out a preconceptual questionnaire for completion by both our clients, and we like them to bring that along with them to their initial consultation, along with copies of any relevant blood test results and or semen analysis results. And the things we're looking for specifically are things like FSH, which is follicle stimulating hormone, luteinizing hormone, prolactin levels, estradiol, which is estrogen and progesterone, and then semen analysis results for men. And we actually like to see copies because quite often they're told that things are fine, and when we get to look at them, they're not fine and they need some remedying. So we start to build up you know, a very good picture of what might be happening for them. The first appointment is consultation only. Okay, so we don't actually do any treatment during that time at all. It is a consultation where we are finding out exactly what the issues might be. And that involves the questionnaire, it involves our own note-taking, it involves any medical tests that they may bring with them. We talk about their fertility history, their gynae history, and general medical history. And for women, we ask very detailed questions about their menstrual cycle and its function. So how long is it? How long do they bleed for? What's their bleed like? Is it heavy? Is it light? Is it clotty? You know, all of those things tell us whether there's stagnation present, whether there's low progesterone levels, etc. So lots of detailed questioning about their cycle. And then once we've gathered all of this information, we carry out what we call a reproductive assessment, or repro assessment for short. And basically it's a very short technique. It takes about 5 minutes, and it allows us to assess their overall health and well-being and their reproductive health and well-being by feeling the reflex points. So to give you an example, in women, if you were feeling ovary reflex points, they should feel different at each stage of the menstrual cycle. So during the bleed, they'll be very quiet, there's very little activity. From end of bleed to ovulation, you should be able to feel a little, it feels like a little pinhead underneath your thumb, which feels like the development of the follicle. And then post-ovulation, you can feel the corpus luteum, this little yellow mass. So that little pinprick has become a little splodge. So you're assessing whether the right things are happening at the right time in their cycle. It just gives you a sort of brief example of how the assessment works. It's a bit more detailed than that, but it's key because it provides us with lots of information. And then what we do is we treatment plan. So if you've got someone who's got an irregular cycle, you'll be saying to them, we need to treat you weekly throughout one entire menstrual cycle. Once we've got that functioning as it should be, then we'll go on to the actively trying to conceive program, which means we treat in weeks 2 and week 3, which is aiding ovulation and improving implantation outcomes. So we have a very structured way of working, and it allows them to know what they're in for, really, and it's almost sort of they know they're going to need to come weekly. They know what's expected of them and of you, and so it's a really constructive way of planning treatment.
Just to let you know, there's 5 minutes left, so
okay.
You know, we'll be wrapping up in 5 minutes. Okay?
Okay, that's great. Thanks, Teresa. I'm just going to go through our stats quickly then. Just to let you know that I do have a book which is with the publishers at the moment. That should be published in February, I think, which really is goes through all of the information that we cover in the course and hopefully supports you as practitioners in that. Apologies for my phone ringing.
It's not me.
If you want further information on training, sorry, it will just stop. Hopefully that might be better. Further information on training, you can get information about all of the courses at our website. And I'm just going to go on briefly to talk you through our data collection results. So we looked at 180 clients with an age range of 24 to 46, and an average number of treatments that they undertook was 11.32. Of those 180, 122 clients conceived whilst receiving reflexology. 100 of these were natural conception, and 22 of them were also receiving IVF or ICSI.
Fantastic.
So we had a success rate of 68%.
Amazing.
Now, it is amazing because the success rate for IVF is 25% and has not changed since the birth of the first IVF baby.
Wow. Amazing. So, absolutely amazing. And congratulations to you for studying all these effects and spending so long of your, you know, a huge proportion of your lifetime gathering all these stats together. Amazing. Absolutely amazing.
Well, I'm just lucky that it is my passion, really. So I think that's what motivates me.
And thank you so much for bringing this to our attention. It's just been brilliant. And even for me, you know, learning more and just finding out more stuff. Like yourself, you just don't stop learning, do you?
No, you never stop.
Never, ever stop. Absolutely fantastic. Found it very, very enlightening. And some people are coming through and saying absolutely amazing results, Sandra Long has said. Thank you very much, Leslie. Connor has put, and Jill from Canada, can't wait for your book. The book will be out soon. So yeah, definitely. I'm really looking forward to when you actually put the book out. If you want to put on my website your website, that would be really good, so people can link into that, if that makes sense.
Yeah, that's great. I don't know what I need to do that. You just need to.
All right, I'll do it. It'll be much simpler. Brilliant.
Okay.
Absolutely brilliant. And sorry. Did you have any other comments you wanted to make, Barbara?
No, only thank you so much for having me because it's always such a joy to share it. So,
It's
it's a pleasure.
You know what? It's one of those subjects that you just want to keep going on and find out more and more and just have a good old conversation with you. I am sure everyone understands what I'm talking about. I wanted to interrupt you so much and have a good old conversation about it. And I'm sure everyone feels like it, but I know you're very busy and I've really appreciated the time that you've taken to come on here, like everyone else has, that are coming through and actually saying that actually who hang on, what Tracy Hell, where I studied this. Okay, so I'll put your website, actually I tell you what, can you put a comment, can you put your website address on the chat box and then everyone
Oh,
will
yes,
get it straight away? That
I,
would be absolutely brilliant.
I will do that.
That would be so good. So then everyone, and you can send it to the entire audience, and then everyone will get it.
Yeah, I
And
think
there
I've put that
there
in.
you go. So now they've got your website. That's absolutely brilliant. Fantastic. So thank you again. Just to let
My pleasure.
everyone know that we've got on the 24th of November, we've got Arv. I don't know whether you've heard of him, Barbara. I can't say his name correctly. He's from Norway. Arv,
Oh, are they?
yes. He's going to be talking
Yes.
about full body reflexology. So that'll be very interesting.
Yes, I've heard him speak of that. I saw him at I was speaking in Madeira and he was one of the speakers in Madeira and also at the ICR conference. So I'm sure you'll find it really interesting.
So we're all going to give you a big round of applause. Thank you so much. Really appreciate
Well,
it. Thank you.
thank you for having
Lovely. Take
me.
care. Thank you.
And you.
Bye.
Bye
Bye.
now. Bye bye.
Bye.
Bye.